Good morning. So sorry for the problem. So I will go straight to the another slide to don't waste time. I have no disclosure about this slide. So this is about my talk. We talk about the past and the present and the 3D image for the assessment and for the future. You can see that in the past that we use a film like that is for the 2D, and then we have the PAX program that they can stack together to can running to see the whole. And this is latest one. We still have a 3D that we can use it for running circle around 30, 60 degree to see inside the whole everything. Previously, I was taught by the many master that told me that you have to imagine everything inside your brain before you go operation, but actually it's not like that because I'm not have the talent like my master. So I think that in every day surgery, if you have a program that can help you to see the inside before you go in, it should be better. If you have a talent like my master, it should be good. But if you don't, maybe you need a program. So why the first about the volume? Why you have to think about the volume? Why volume is matter? You can see this is a Bakushi decision tree that we use more than 20 years. Bakushi is select the operation by using the ascites, the bilirubin, and the ICG level, which means that if everything is good, so you can do whatever you like. I think it's not true because of something is have a matter. You can see that if you have the patient like this, the right side is a very big tumor, and in another case is have the tumor on the right side too, but it's a very small one. If these two patients have same parameter, same ICG, same bilirubin, no ascites, what do you think that which one is have a problem after right hepatectomy in the both case? You may think that yes, in the small tumor may have a chance to have a problem. That's why because you remove a lot of normal parenchyma or structure of the liver, which means that you think that volume is better. So for the volume that you can have many things that you can calculate. You can make a volumetry. Previously, we have a drawing by our hands. That is the latest one, and the newest is use a program to make the automate. I will review that step that we make for the volumetry. In the previous one, we use something like this. This is a case sample. It's for tumor on the right side. You have the 3 steps to calculate. Calculate the tumor volume first, the total liver volume, and then the remnant volume. For this case, if you calculate for the tumor volume, you see that tumor volume is just 37 cc. And the next step, you go for the calculate the total liver volume, which include the tumor. In this case, it's around 1070 cc. And then you go for the remnant. You plan for the right hepatectomy in this case. So you make a volume on the left side, which is around 279 cc. Then you go for the formulate. The first one you have to calculate is a thing about the total functional liver volume. You should calculate only the volume of the liver only, not include all the tumor, cyst, benign, or the vessel, everything inside. You should subtract everything. We see how you have using the total liver volume and then subtract by the total volume. In this case, the TFLV is 1030 cc, and then you calculate for the FLR by using remnant, multiply by the 100 and divide by TFLV. In this case, the remnant volume is 77%. So this is basic for the calculation. You should take a 3 step to calculate by your hand if you use a manual. The problem nowadays is about the CT scan that is very advanced. We don't use a 10 millimeter, 5 millimeter anymore. I think in every hospital now, we use at least 3 or 2 millimeter. In my hospital, we can do for 0.5 millimeter, which we have around 500 to 600 images per liver. If you calculate by your hand drawing in every slide, in the CT scan that very advanced, you may take around 6 hours or a day, which is not good for calculation. And another limitation, not only the slide, is sometimes you found that you have a complex inside the liver, something like you make the PVE, you make a TACE, you make have a lot of inside parenchyma tumor, And how you can draw in everything, you can subtract everything, is not possible by your hand. This is some kind of limitation. So for the program that we can use now, I will show you the real time. This is video, just only 1 minute for calculation for one patient. You can see this is in real time. So the first will calculate the total liver volume. It's just around 5 seconds or something. Then you get them simulate the IBC, maybe 2 or 5 seconds. And then this is a little bit long. It's calculate the vein inflow and the outflow. It takes around 10 or 20 seconds. This is I not trust the quicken or the video. It's my real time capture from the my program. Then the last is you calculate the tumor volume. It not takes much time. Then you observe everything and ready for the calculation. Just a few clicks. You can see it's ready. Proceed inside everything, calculate everything too, just in 1 minute. It's better than the past. So the next is about the calculate, about the analysis and the simulation. Previously, we think that this program is good just only to see the anomaly. Yes, you can subtract everything you see inside to check the anomaly, but not just that. Maybe you can see the learning anatomy to review the film before the operation, to see the segmentation like this, the dorsal ventral and cranial caudal, or the full segment of the anterior section. This is very good to review before you operate in every case, and not only just to review to see the anomaly, maybe they can help you for decision. This is all the example. For the case, the tumor in here, if it's benign, you may go just only the segment A resection, it should be okay. The remnant is very big. But if it's a cancer, if you want to make a anterior, okay, you can calculate. Just few click. Or you want a right hepatectomy, okay, yes, you can. But what is good, if it's in some time, if you calculate the right hepatectomy is not enough, you should be aware when you operate that if you make a right anterior sectionectomy, you should not injury anything that force you to make the right hepatectomy, because you already know that right hepatectomy for this patient is not enough. That means that this is some kind like a protection that you can know before you can operate. If you think that some area that is very dangerous is injury that it make you force to make right hepatectomy, you should avoid it. Not only that, you can make a plan. For example, the case like this, tumor on the segment 7, and you can see that you may plan for the segment 7 resection. You make a simulate before you can go operate. You can see that this is a patient lie down like this. You make them the pneumoperitoneum. I will show you again that you can see that is a domain is flattening, and insert the air like a simulation. And then you can try to make a place of the trocar. And here, the normally location of the trocar, the first one for the camera, usually you look for the umbilical. For this patient, you can see that if you make at the umbilical, it's like this. You see it's look okay. But for the inside, maybe you don't know. But by the program, you can see inside, look closely, and try to look inside at what it look like when you insert the camera. It's something like this. You can see that it's okay. It's a little bit too low for the location like this. So you make a move for the location of that you place the trocar to above just 5 to 6 centimeters, and make the observation the same. You may see that, okay, in this area is look okay, but what about inside? You go in, okay, location is look good at the upper part of the liver, but you can see the tumor, so you can remove inside the structure everything. You take the liver out, and then you can take the vein. So you see the tumor is here, I think that this location it should be appropriate for the trocar. You can make this before you can go operate in every patient. Not just only you can simulate on your desk, you can use in your operation room by connecting the line. And not just only that, you can make it on your phone or your tablet. You can show this to the patient, for the family, to discuss with them, to show them that what you plan, you can review before you can go operate. You can see that it is in my phone in this case. So I see this area that I have to cut. So I take it out. So I can see inside, I can see the structure, the tumor, and review that at which plan we can go in, which vessel we can keep, which vessel we should be cut. I think it's really good. The next one is about for the navigation. The navigation is something that we try to concern about this many times, long times ago. Previous one we use a model. It's a very big one. You have to print by the 3D, and now it's just some kind like for the education. It's not used anymore because it's very big, very heavy. And the thing that is concerning is about that it's not a real liver. When you cut the liver, you split the liver. The inside the liver is moving, but the model is not moving with you, which means you face with the deformation problem. This model is cannot conquer the deformation problem. So that's why we don't use this anymore. Some program that try to overcome this, we have these two programs. This is one of the two that try to make a registration by use a camera in the room at the top of the operation desk, and registration with the 3D image you already made, and then they guide you for the make the operation or the ablation. But the problem is the same too. It's about the deformation. If you change the position of the liver, if you cut the liver more deeply, the inside is a 3D that you already made is not moving with you, which means that you have to re-CT scan every time you change the position, make a new 3D, make a new registration, which wastes your time, and then just to operate in the CT room. That's why this program now is no one using anymore. It's something like this in the robot that we have someone using the embed like this, that by image the film is like this on the area. It just only make only the weight is okay, but for the operation that you're tracking the liver is still not usable. What we can use now, if we don't have the thing that overcome the deformation, you can still go back to the basic by looking for the intraparenchymal structure as using it as a landmark. For the case like this, you can see that we plan for the segment 8 to remove the tumor. Then you make a simulation. You can see that this patient have the 8V and 8D, and the vein that the AFV is underneath the tumor. So looking like this, you can see that the problem is a thing that inside that when you operate, you cannot find the segment 8 very easily if you don't know where to find it. The guide that we use in this case, we use a small vein. You can see the V5 that is very closely to the segment 8 pedicle. If you find that one, you should find the 8 pedicle is close to it. It helps you to not get lost in your operation. So this video. Okay, I will skip because I lost a lot of time. Oh, sorry. Okay. Okay, they don't allow me to control. It's okay. So we can see this together. So the first you take out the gallbladder first, and then you try to go in the hilar, take down the hilar plate. And you aiming for see the segment 8 by finding the anterior pedicle first. Yeah, this is anterior pedicle. You go upward, dissect open parenchyma and try to encircle. This should be the segment 8 that you see in the film. You try to clip it, and for that it's just only 8 ventral, not cover all the 8 ventral and 8 dorsal. So you go as a plan by open the median candili, then you dissect to identify the middle hepatic vein. So when you see the branch, If you remember, you have to cut the 2 branches of segment 8 and 1 branch of segment 5, and the another less one is the anti-diffusion way. So this is a segment B8 and the anti-diffusion underneath it. After that, you can follow the metahermetic vein to identify the V5 that we already planned. This is that one. It's very small one. You should to encircle the clip and cut it. You should cut it because if you don't cut it, you can open the space more to identify the segment 8. After you cut it, you see that close to it, after you make a more dissection, you see that is a clip that you already clip on the V8. Yes, it's exactly the same location that you see before you can operation. And then you can separate it to the 8 ventral and see the 8 dorsal. You can see that the 8 dorsal is lying down on the back, which is very difficult that you can encircle at the first time when you go in the highlight. So after you remove the clip, you going to cut it. This is for the ventral. Is whatever you like is a staple, the clip, the hammerlock, whatever you like is okay. And then this sec for the dorsal that lie down on the back. For the dorsal, it's quite smaller. If you use a clip, try to remember that 2 clip is better than 1. If you have a chance to clip another one, try use the second one. So after you cut it, you can inject the ICG, and you see the emit and non-emit area is a whole segment 8 and the remnant. You can follow to dissect it along the emit and non-emit area. You remember the last one that you have to cut is this one is anti-diffusion vein. But if you do remember, anti-diffusion vein root is not in the plane. It's in the paracaval portion, which means that if you go for the root, if you cut it at the root, when you open the ICG, you will see that you have to cut some emitting area with it. Okay, then you go for the right, for the boundary. Okay, the operation is finished. So for the future, I will show you the video clips from the program that is the newest version. I see the Fujifilm at the back. Please bring version 7 come to Thailand now. Now we have a 6.8 for 2 years. So this is for version 7. You can see that they try to overcome the deformation, which means you see this patient tumor on the left side, and on the right side it is structured like this. So you can put the point to track it, to make a traction as you operate in the real patient. But the problem is still about the contour, the texture of the liver is still not the same. You have to put it inside that some stiff liver, some non-stiff liver, some fatty liver is maybe, but it also is very good to for starting for the prototype. You can make it overcome the parenchyma structure inside when you lost it, which means that if you embed it in the operation like a laparoscopic in the future, you can follow inside, you can see that which one you need to keep, which one you have to cut. It should be safe for your operation. So for the conclusion, the CT volumetry advancement has come so far from the past. Currently, there is a 3D program, a lot of 3D programs that have a variety in application. Choosing the appropriate program for the situation will ensure the smooth surgical planning. And if it's necessary for the modified surgical plan for the program can help to design the best and the most precise treatment for the individual patient. So this year at October, we have the APHVVA. I would like to invite all of you if you have an interest in the HPP surgery. Thank you.